Good evening, everyone. Firstly, apologies for the interruption. This meeting is being held bilingually, which means you are welcome to contribute in Welsh or English. For those of you that do not understand Welsh, please do the following. Scroll to the bottom of your screen. There you will see an interpretation logo. Please click on that and then click on English. Good evening and a warm welcome to this online public engagement meeting. Welcome to our guest speakers. Firstly, I would like to explain that I am a voluntary member and chair of the local Cardiff committee for the South Glamorgan Community Health Council, and I am joined by the Chief Officer, Stephen Allen. The Community Health Councils are the only independent and public and patient lay NHS watchdog in Wales. One of our key responsibilities is to represent the interests of the patients and public in the NHS. This evening, my role is to chair this engagement meeting and act as the honest broker in discussions. As a CHC member, I have no preconceived options as to whether the proposal has been presented tonight. However, I am clear that my role is to ensure that the meeting is carried out in an orderly manner. This evening's online engagement meeting is to discuss the proposals from the Cardiff and Vale University Health Board entitled Shaping Our Clinical Services. House rules to be followed during the meeting. To help keep background noise to a minimum, make sure you mute your microphone when you're not speaking. If you wish to ask a question during the meeting, you will need to have your video camera on and name on the screen unless you're using the phone audio channel. If you choose to use a webcam, be sure it is in a stable position and focus at eye level if possible. Everyone's view is important, so respect what they say, even if you disagree with them. If you want to speak while someone else is speaking, raise your hand and the chair, or rather Mr. Allen, will invite you to speak when they have finished. Inappropriate behaviour will not be permitted in this meeting. Individuals will be given 2 warnings. If they carry on, they will be automatically removed from the meeting. Before I introduce the main speakers, I would like to draw your attention that an online response form, which has been emailed to you and is also available on the CHC and Health Board websites, can be downloaded, or if requested, can be sent to you by post. Also, as public bodies, the CHC and Health Board have a duty to take into account the impact of their decisions on people with protected characteristics as laid down by the Equalities Act. To assist with this, you are invited to complete the online questionnaire, which has been emailed to you and emailed back to us. Therefore, I am delighted to introduce you, or rather, introduce to you the Cardiff and the Vale University Health Board, who will introduce themselves. So welcome to the meeting, and please will you introduce yourselves as you speak.
Thank you, Chair. My name is Jan Janchevsky. I'm the Chair of Cardiff and Vale University Health Board. I'm delighted to be with you here this evening. So, noswaith pawb, croeso I gyd. Good evening, everyone, and welcome to you to our online engagement event with a very exciting programme of work for us in Cardiff and Vale University Health Board. If I may, I'd like to thank the Community Health Council for agreeing to host this event and the events that have gone before and those that are due to come. It's very important that we have that independent sharing, so much appreciated. I'm joined today by other representatives from the Health Board, and they include Abby Harris, who's the Executive Director for Strategy and Planning, Dr. Nav Masani, Associate Medical Director for Clinical Strategy, and Nav is also a cardiologist, and Victoria Legree, Programme Director for the Clinical Services Plan. As a health service, we acknowledge that we do not work in isolation when we try to improve or develop our services to make things better for our patients and staff. We need your support, please, and the contribution from our communities. At Cardiff and Vale, we're probably in quite a unique position in many ways, as we not only provide health service for local communities across Cardiff and the Vale of Glamorgan, but very often across South East Wales and also all of Wales and in part the UK. It can be a very complicated picture to convey, but hopefully through the presentation and discussion tonight, This will help you to perhaps understand a few points, and in particular, the scale of the challenge facing us as a health service, why we need to change and to do things differently. And as I'm sure you're all aware by now, we're very mindful of the impact of COVID-19 on developing our health services so they're fit for the future. We're incredibly fortunate in Cardiff and Vale to have a diverse and culturally rich population, all with varying health needs at different times of our lives. Our aim is to ensure that everyone has the opportunity to lead a full and healthy life, no matter who they are or where they live. So the provision of future services is vital to ensure that we reduce health inequalities and give everyone that right. Our task is not just to think of providing health service for the future, it's also for the here and now. It's ensuring the decisions we make now are sustainable over the long term and that they can make a real difference to people's health and well-being. We refer to that as improving our outcomes for patients, and it's one of our key principles alongside caring for people and keeping them well. Please make the most of this opportunity this evening to ask questions and get involved. We really need your involvement, please, in these very important but also exciting health discussions on the future of yours and my health service. I'm now going to hand you over to Vicky Legree to take the next few slides forward. Diolch yn fawr. Vicky.
Much, Jan. I'm just going to share my screen. I have a few slides to share with you. I'm just looking for confirmation from somebody that they can see that.
Yes.
Hopefully you can. Shout if you can't. So thank you very much for attending this evening. We just wanted to take 20 minutes or so just to talk to you about the work that we're developing within the Health Board. Now, most importantly, that includes some changes that we're thinking about and what this might mean for you, our public, and our staff. We really want to take this opportunity to test our thinking at a fairly early stage in terms of our delivery of our plans, so that you can inform the way that our clinical services are developed in the future. So we launched our strategy in 2015. We're now about halfway through, and that was really to support us in our mission to care for people, keep people well, and make sure that we can deliver on our vision to ensure a person's chance of leading a healthy life is the same, no matter where they live or whoever they are. And just on screen there, we wanted to share with you and just a reminder of the key areas within our strategy that we're looking to deliver on. And you'll see that reflected in the slides as we go through the presentation. I just wanted to mention that at the bottom of the slides, what you'll see in green are some questions that we're asking our public, our stakeholders, our staff to answer. So those are things to have in your mind as we start to go through the presentation. So in Cardiff and the Vale, we oversee and are responsible for services not only within our specialist hospitals, providing services for both our local, our regional, national population, and in some instances across into NHS England. But most importantly in the community, in primary care, in the development of health and wellbeing centres and wellbeing hubs, which Dr. Masani will talk about further on later in the slides. And importantly, that role in public health in terms of promoting health, promoting prevention. And the clinical services agenda and plan will have a role in terms of informing that public health agenda as well. So 5 years in, we've delivered a number of things, and here are just a few highlights and examples. But that real delivery of care close to home in terms of the development of the wellbeing hubs and wellbeing centres is crucial if we are going to deliver really transformed clinical services for the future. Trying to direct patients and support them so that they can see the right person in the right place the very first time. CAV 24/7 is a sort of recent initiative that we saw happen and develop over the pandemic in terms of reducing that waiting time for patients within the emergency department. And importantly, our role as a specialist provider for the rest of Wales, and this example is the Major Trauma Centre delivery, an important part of specialist services within UHW. More recently, I think the last 12 months have really seen huge challenge to our staff and to everybody really in terms of dealing with the pandemic and the problems that it's given us. Importantly, I think what it's allowed us to do actually is see some real innovation within our services. Our staff have really risen to the challenge in terms of delivering care when patients can't come to hospital. And it's been hugely important to learn those lessons and to take the best out of it. And that's what we will try to do in developing our clinical services for the future. So our case for change really hasn't changed. Why are we doing this now? We are continuing to see a growing population. We're continuing to age as well. But also the last 12 months have seen a real added impact in terms of our mental ill health. And it's not getting better, it's getting worse. And we need to address it, as well as obviously the health and social inequalities that we see within our system already. We recently held a number of clinical strategy workshops with some senior clinicians and managers from across the health board, just to test some of the high level thinking. And our workforce and our buildings were two of the areas that came out as real enablers if we're going to change the way that we work in the future. And a huge challenge for us, which is why we often see service change. A huge challenge in terms of the ability to attract, retain workforce right the way across the NHS. And we are one of the biggest employers in our region with over 40,000 staff. So really a huge challenge in terms of training, recruiting, and keeping hold of those staff to deliver our clinical services for the future. And we might need to think differently about the way in which we do that if it's to be sustainable. And our buildings, a number of our buildings now, we are aware, are not fit for purpose for modern medicine. And we need to develop them if we're going to have a chance of really progressing with our modern clinical care in the future. UHW is just an example of that. University Hospital of Wales was planned in the 1950s. It's not fit for purpose anymore, and it's not the best place for patients to be cared for or for staff to work in. So it really does need a development. There are huge opportunities coming, and we need to embrace these as well as also looking towards our challenges. And those include the use of genetic information for precision medicine. We've got huge opportunities in the way that we can prevent and not only treat illness in this day and age. And that's only going to develop, especially as we see our new researchers and more investment going into supporting those people to develop the research. And digital technology, I've already mentioned. But that's digital technology and the changes that are happening that can support us and support our staff to develop, not only to support us to deliver care closer to home, as we've seen during the last 12 months. Most importantly, as such a large provider of care and a large employer, we have a real role within the economy in Wales, and also a role in terms of tackling the climate emergency and making sure that our services are sustainable for the future. So you'll see later on in the slides, we talk about why that's important, how we might do that. And I'm going to hand over at this point to Dr. Masani, my colleague, who's going to talk to you a little bit about our new programme of work.
Thank you, Vicky, and thank you to the CHC for hosting us once again. I'm Nav Masani. I'm a cardiology consultant working in Cardiff for over 20 years, and I live in the Vale. I'm pretty excited actually to be the clinical lead of this programme of work, which takes our principles as spelled out in Shaping Our Future Wellbeing and develops it into a plan or a blueprint for how we can actually deliver that change and that transformation of future clinical services. And this element of the programme is called Shaping Our Future Clinical Services. So we're predominantly talking about services for patients who have got illness or medical conditions. This part of the programme links very closely with the integration of health and social care, and it links very closely with disease prevention, health promotion and public health. But this element that we're talking about tonight really is the clinical services. And the programme we have designed in its infancy really, but one of the core principles is that it's led by clinicians, so doctors, nurses, therapists, scientists, multiple others. And we've been engaging with those groups quite extensively recently. So optometrists, dentists, podiatrists, third sector, all of these groups are involved in our initial engagement and will be part of the redesign of clinical services, bearing in mind though, of course, that it's wrapped around patients. So in other words, patient-centered, designed for and wherever possible with patients and their carers. And rather than focusing on an individual service or an individual location, we want to design our future care pathways along the patient journey from home to home. So really catering for the entire health condition for that particular patient, with seamless integration wherever possible between different agencies involved, different specialisms involved, different healthcare and social and other organizations involved. So that seamless integration is key to the delivery of ideal, high standard, best practice and evidence-based care. And so that will need to be done in partnership. So this is obviously one of the forums for engaging in partners, but we're doing this extensively. Next slide, please, Vicky. So pathways of care really refers to that patient journey, and we've bundled them together for the purposes of this part of the presentation into 3 main groups, which are widely used elsewhere. And I should say that pathways of care and this way of thinking is gained a lot of credence in the scientific and healthcare communities, but also locally on the ground with people who matter, and also with Welsh Government, who've today, I think, published their National Clinical Framework. And it's very much based along pathways of care. So this slide talks around planned and elective care. The next slide talks in much less detail around emergency and urgent care, and then regional and highly specialized, what are called tertiary service care. But I just want to use this slide as an example for our kind of current thinking and the way these discussions are going. So for planned and elective care, to give you 2 examples, investigations and treatments that are arranged and planned. Could be new onset, could be long-term conditions. Examples would be a painful hip, which may lead on to certain kinds of treatments, including potentially operations and then rehabilitation, or going to your GP with a stomach problem that might turn out to be relatively easy and harmless, easy to fix, or could turn out to be extremely complex, like a cancer. These are planned and elective care. And what people have told us is they want rapid access to efficient, protected diagnostic and treatment pathways. So protected means that it's safe in terms of a planned date, no cancellations, no delays, a planned course of treatment or diagnostics, safe from things like cross-infection or safe from staff shortages. So really dedicated, planned and elective care. Wherever possible, this should be close to home or even in the home. And when it involves complex and sometimes multiple different specialty needs, we want that care coordinated as far as possible. And I'd just like to step you through a modern or future care pathway for this group, the planned and elective care. So along the bottom there, we start on the left of the screen with a patient or a person who has a new problem. In the past, the choices were relatively binary. You may see someone in the GP practice and then someone in the hospital, and then bounce back and forth between hospital and primary care for investigations and treatments. And we've already made significant changes to this out of necessity during the pandemic, including in many of my own specialties within cardiology. However, what we would like to do is develop them by design, so they're optimized and ready for the future. So currently, if you now visit your GP or have an interaction with your GP, the GP surgery can interact with a specialist without the patient having to transfer to the hospital. So we've got apps, we've got online dialogue, we've got various ways of accessing a dialogue between primary care and specialist care without the patient having to travel. We're developing the concept of community hubs, which is a worldwide concept really, where certain tests, certain assessments, and even certain treatments and follow-up can be undertaken closer to home in the right environment, not necessarily in the sort of heat and hustle of a major hospital. If patients have had tests or assessments in community hubs, we're now able to contact patients in their own home, either by telephone or video, however they prefer actually, and using the technology that they're most comfortable with and have access to. Clearly it will be necessary in the planned and elective care pathways to undergo tests in hospitals and treatments in hospitals. And those are represented by the two red blobs in the middle of that pathway, if you like. Now, clearly, when that's necessary, what we want is world-class care by the right staff, with the right facilities, safe from infection, protected, if you like, from emergency work streams that offer those risks. In between hospital visits, we're putting in place ways of feedback and monitoring. These are patient-reported outcome measures and patient-reported experience measures. And so we're able to stay in touch with patients through the use of apps more than we have been. Follow-up after hospital treatment, again, a blend of community hubs where appropriate and where the quality is best actually, home, hospital if only necessary, and again, that blend of things at home and primary care in terms of follow-up. And when I talk about follow-up in primary care, that doesn't necessarily mean the traditional role of GPs. It might be that people such as myself actually see patients in hubs and general practice, as in fact we have been doing in community cardiology clinics in North Cardiff Medical Centre and Rumney. So it's a new way of working, it's a new blend of facilities and options that we've got, adhering to those principles of shaping our future wellbeing, and of course the All Wales, A Healthier Wales Welsh Government paper on health. So next slide please, Vicky. In much less detail, we're planning the same principle changes to emergency and urgent care. So these are life-threatening or life-changing conditions that need immediate and potentially intensive treatments, such as severe chest pain that may be a heart attack, head injury that may need a trauma team, or even a neurosurgery, that means brain surgery team. And in this example, we want to identify pathways that take the patient to the right service in the right place as quickly as possible. Where that is possible, it will still be in the community rather than necessitating transfer to hospital when it isn't the right place for those emergency services. But that does mean a big piece of work around our staff providing access to safe care 24/7. And that's the challenge perhaps with emergency and urgent care. It does mean following the principle though of streaming the patients to the right service, wherever that service may be. And the same principles apply, but just on a wider footprint for highly specialized or tertiary services. We've got a responsibility and a privilege, in fact, of offering some of those highly specialized services for the whole of Wales or for the whole of South Wales for complex, uncommon and rare conditions. But again, if that patient is in West Wales and what they need is care closer to home, again, using technology, using new ways of working, using collaboration and integration across organizations, that would be the aim of redesigning tertiary services or specialist services care pathways. And as you can see along the bottom there, the question we're asking is, are you supportive of these principles that we have set out in relation to these pathways? Next slide, please. So we've got an open mind, and we're engaging clearly with a wide group of people as to where those services may be best located. I think everyone is focused on the buildings, if you like. Everyone is focused on what services are going to be where, and this is work in progress. Certainly offering clinical services, not social as such, but clinical services at home is a reality. And we're getting rich feedback around that. My initial concern really was perhaps the older group of patients who perhaps we had a preconceived idea weren't au fait with the technologies, but actually our experience is that older patients during COVID have been the very ones who have been really anxious to avoid hospital visits. And so we're picking up that feedback. Clearly, we need to make sure that each individual patient is offered the right home or close to home facilities for that person. There are vulnerable groups, there are ethnic minorities and language issues to overcome. So that's, again, work in progress. And we were speaking to lots of third sector organizations this morning around that very subject. We published a plan 5 years ago for 3 main health and wellbeing centres in Cardiff Royal Infirmary, Barry Hospital in North Cardiff. And these are actually areas where we will have some medical facilities. Exactly the specification for them is, again, work in progress, as it is across the whole of the UK, actually. But for the purposes of this discussion, in terms of clinical services, we're talking about diagnostic services such as X-ray, ultrasound, maybe more than that, outpatient, GP, out-of-hours services, ideally suited, of course, for community mental health teams and children's services, where, again, the ideal environment isn't the hospital in all cases. Wellbeing hubs are a slightly different concept, grouped to allow for health and social care integration around the 9 localities, the 9 primary care clusters. So there's a plan to develop some of these areas. And again, the plans themselves are still in development, but there are areas, again, much closer to home, where we can have that combination of health promotion, signposting to the right services, some clinical services, some social and clinical overlap, less technology in these areas, but again, reaching patients who are traditionally harder to reach, minimizing the carbon footprint, minimizing unnecessary transport onto the over-congested hospital sites. And I think one of the elements that we're really understanding is that this element of the plan, shaping our community care, and that working in partnership is crucial in terms of all of the rest of the elements working as well. We can't go to that model of a future care pathway that I outlined unless all the elements along that pathway are developed, are fit for purpose, are high quality, developed sort of in conjunction and in parallel, working across the different sort of traditional boundaries and breaking those boundaries down, actually. So next slide, please. In terms of the 2 main hospitals for clinical services, part of our Shaping Our Future Hospitals programme, it all sits under the banner of Shaping Our Future Clinical Services, if you like. Again, without going into detail, because the details are not hardwired, it's work in progress and we have an open mind. Our vision is for 2 major centres of excellence. One focused a little bit more on the services that have to be grouped together to offer 24/7 high intensity, emergency, high acuity care. And so that naturally fits with things like major trauma, neurosurgery, intensive care, and therefore pulls in things like emergency medicine, emergency surgery, heart attack, stroke. And there's a natural clinical fit between those services, which have a lot of codependencies, a lot of interdependencies. So they group together, whereas in the past, things have tended to grow a little bit in a fragmented fashion. So this offers much more of an opportunity for alignment and a streamlining of clinical services. It goes without saying that our vision is for a state-of-the-art facility, particularly if you focus in on the high intensity, high medical technology components of that particular patient group. But we want it to be sustainable, energy efficient, playing our part in the climate emergency. It needs to be a healing environment for those sickest patients. And we know we can't offer that right now. But we can't offer, for instance, modern day safety in terms of cross-infection within the existing facility. And again, COVID-19 has really highlighted some of the issues that we're grappling with. It also needs to be the optimal learning environment, both for Cardiff, but actually for all Wales. It is the platform for the University Hospital of Wales, not just for the local population. And so we have an all Wales role in terms of teaching and research. So that optimum healing environment and the optimal learning environment. The counterpoint to that is that we need to protect our patients who need that kind of planned, safe, predictable, elective pathway away from the hot and highly risky emergency type. So equally, there's a nice alignment and a fit between planned services in its own centre of excellence, taking forward the principles, if you like, of CAVOC, the Orthopaedic Centre, or the Breast Cancer Surgery Centre that was already at Landock, other services that we have moved there for safety reasons during the COVID pandemic, but also for patients who need hospital care but are stable, more of a focus on rehabilitation, state-of-the-art rehabilitation when we move the brain and spinal injuries units over there to join the stroke rehabilitation units and others, but also elements like inpatient mental health services, patients who are immunocompromised and who need planned care, such as cystic fibrosis patients, again, away from that hot emergency stream of patients that we currently envisage for the UHW site. So those are broad brushstrokes really of the major hospitals plan. There are other elements that we're growing, and clearly we are trying to take rapid steps, but in the right manner, listening as we go along, listening to our own staff as well as patients, public and other groups. So next slide, please. And that principle is borne out in these important considerations. So our staff are our most important resource. We know we face very significant challenges in the recovery phase from COVID, and I think that will stretch to the medium term as well, over and above NHS workforce challenges that were already there. So to undertake this kind of transformation, you'd wonder about whether or not the timing is right, but in fact, we've had a very, very big positive response from our staff, who I think more than ever see the need for change and are embracing the need for change. We're cognizant that there's an absolute digital revolution out there for healthcare, but again, it needs to be done in the right way, as enablers, not replacing traditional clinical interactions. And of course, there are other challenges to us as well in terms of things like training the future nurses, doctors, and others. How do you do that if we're not in the same room as our patients? How do you offer security, communication, and data protection, and so on? How do you really take advantage of things like wearable devices that can monitor health conditions or send alerts to the healthcare community when necessary? And again, we're well aware that Wales really was leading the world in terms of hardwiring a response to the climate emergency into the public sector responsibility with the Wellbeing of Future Generations Act. And we want to play our maximum part in combating that, but as well as promoting health and well-being with active transport and reducing pollution and so on for our own local populations. So those are the major brushstrokes of shaping our future clinical services. And it's that we're really asking for your engagement on. As you can see, the question there is there anything else we should be considering when transforming these clinical services? And then the last few slides, I'm just going to hand over to Abby, who's just going to take us through how we're going to use the feedback that we're currently getting.
Yeah, thank you, Nav and Vicky. And good evening, everyone. I'm Abby Harris, and I'm the Exec Director of Strategic Planning for the Health Board. So just wanted to echo my thanks that Jan made about the CHC hosting this meeting. Really very grateful to colleagues for hosting. So just let me run you through the next stage. So this is one of a number of engagement meetings we're holding to hear views from public and local communities. It's by no means the only vehicle through which people can share their views and get involved in conversations. So I think, as Nav and Vicky have alluded to, we've been out to talk to lots of different groups and happy to continue those conversations. We're also getting feedback through questionnaires that are coming through with us and survey work that we've undertaken. So when we receive all of that information and material, we will analyze what we've heard, what people have told us. What we tend to do is group it into themes. We generally find that there are a number of themes coming through what we've heard from people. And we will pull that together and share that with the Community Health Council to talk through what we've heard, to check through with the CHC that we've kind of interpreted that what we've heard, and share with the Community Health Council everything that we've received back. We're very happy to share all of the feedback through whichever channel we've received that information. So the engagement runs until the 19th of April. We've got a further public meeting this week, and then the rest are mainly meetings with different stakeholder groups. Following the conversation with South Glamorgan Community Health Council, the council will have a chance to consider it, I think, through the executive committee meeting, and then we'll take a recommendation on our way forward to our board, hopefully in May. And we'll take on board the views from the Community Health Council, and it'll be based on what we've heard. We'll make sure we feed back to local communities and people who've engaged. So we've got the importance of keeping a list is that we can provide people who want it feedback on how the plans evolve. And there may be areas where we need to undertake more detailed planning. In fact, there very much will be, as Nav described. In many areas, we're kind of at the start of our journey, and we've described outline proposals here. And what we will do is take those views and they will help us shape more detailed proposals on how services may change. And that will include where we provide services, how we provide service, reflecting on the things that Nav and Vicky have described. And it is likely that later on in the process, we may need to come out and undertake consultation. So this is an engagement session, and it may be that we need to undertake consultation as the plans and proposals get firmed up as we go through the spring and the summer. So this is the final slide, I believe. So it's just reminding colleagues and participants of the number of different ways that you can get in touch and find out more information. So I think the feedback form has been emailed to everybody who was signed up for this evening. We have a lot of material and more information on our website, shapingourfuturewellbeing.com. You can email us and you can contact through the Community Health Council as well. So many different ways. And for us, the more voices we hear and the more feedback we get, the richer the conversation and the richer the discussion. And that will really help us shape our thinking as we move forward. So this is just a bit of a recap on the sort of questions we posed throughout the presentation. Really want to hear about what we've described and the principles that we've set out, and really to check out with people that we haven't missed anything, or and to hear from you what the most important things are based on the things that we described this evening. So probably with further ado, I'll hand back to Jan, our chair. Jan, do you want to say any concluding comments before Val opens up to questions?
Thank you, Abby. Just to really emphasize the point more than anything, that this is an engagement process, and we're looking at shaping our services, not dictating what we think they should be. That's why your input tonight, everybody, is so valuable to us, please. It's all about how we position ourselves in trying to look after our patients and build our services around the patient, rather than making the patient always travel to the service, as far as possible anyway. So your input is really valuable to us, and it is a case of you will influence the way forward. So please have your say. Thank you, Chair.
Thank you. I would like to thank the Health Board for their presentation, and it is now your turn to provide comments, questions and observations, all of which will need to be noted for reference as part of the engagement process. Ideally, I want to afford all present an opportunity to have your say and not cut short any debate or discussion. I would like us all there to adhere to the following requirements. Firstly, could all speakers please give your name, and if you belong to an organisation, the name of that organisation and your position within it. This is purely to assist those taking notes. Secondly, it would be appreciated if only one person would speak at a time. Again, this is to assist everyone at the meeting and to help the note taker record the questions and answers. Thirdly, I am sure that I don't have to ask attendees to conduct themselves with dignity and refrain from engaging in any personal attacks or act in an aggressive manner. Finally, I will ask questions and attempt to limit them to one per person in the first instance, in order to allow as many people as possible to contribute. It is also my intention to finish this meeting if possible, no later than 9 o'clock. Could we have the first question, please?
Chair, Mark Wilson's got his hand up.
Okay. Mark?
Okay, yeah, hello there. Thank you very much for that very interesting presentation. And I see this as very exciting. By the way, my name is Mark Wilson. I am a Vale Glamorgan councillor, Penarth Town councillor, as well as working for CAVC, which is Cardiff and Vale College as well. So basically my question is, I mean, one of the issues I think we have a major challenge is access to technology. Now, that is a real fundamental issue for many people who want access to healthcare. And I just wondered, perhaps, has the Health Board got a plan in conjunction with Welsh Government to look into access to technology so that people are not only able to access it, but also feel comfortable with using it?
Thank you, Mark.
Abby, do you want to respond, or shall I respond?
Yeah, I'm happy to kick off, and Nav, you might want to contribute. And Mark, thank you for that question. That's really helpful. And we are very mindful of the digital inclusion agenda, and we're working as part of the Wales Cooperative Centre's work on digital inclusion. I think one of the jobs for us is to look at how we can support people to use technology differently. I'm very aware that there is another area, not in Wales, but where actually they included as part of a prescription providing iPads and things like that, so people could use the sorts of technology that Nav was describing to access services if they didn't have those facilities themselves, and that actually they could be loaned out and be part of the support we were able to provide. And I think that's the sort of thing we would like to be providing. Those sorts of things can be provided through the Wellbeing Hubs and the Health and Wellbeing Centre, and delivered hopefully in partnership with the councils. Again, very much aware that the council's doing quite a lot around digital inclusion, and presumably we'll have a lot to learn, or will have a lot to learn in terms of how children and young people have access education online. So a really important point, and yes, something that we have got on our mind. Nav, did you want to add anything?
Yeah, can I just respond on that? I mean, clearly in education at the moment, as a teacher myself, I'm very much aware that an awful lot of us, including myself, have been doing things online, and there is a deficit here, because even with the best will of Welsh Government and the councils, there's still many people I know out there, and either it's not just because maybe they don't know about it, or they feel they've got too much pride in applying for technology as well, especially amongst younger people, where it's very much, you know, they don't want to say they haven't got X, Y, and Z. I quite understand. I remember it all too well, going back to personal stereos when I was a teenager myself. You know, you always wanted the best one. If you didn't have it, you were quite embarrassed. And it's the same kind of issue that is out there. And I think will be, you know, a lot of people say we cope. And really, that's not good enough, because it will mean they really won't have access to the right kind of services. So we do need to break down those barriers. I mean, I think in this post-COVID age that we're going to be living in, that it will present it to be a major challenge, because there will be clearly people who have got probably underlying health issues who are pretending, I can cope. I got a bit of pain, I can cope. You know, and really, we know that those people could be suffering from major serious illnesses. And really, I think we do need to speed this up, because I know out there, even in Penarth, different you know, surgeries, for example, have different websites, different ways of doing things now, and some are a lot more sophisticated than others. You know, you don't have to be, you know, a surgeon, a brain surgeon, to see that. You can quite easily see that yourself looking at that. And I do think that's an issue that we need to look at in terms of equity of access, because I know it's not there now.
Mark, Abby, do you want to reply to that?
No, just to say that I agree with you, Mark. I think it's something we need to be really mindful of. And also there will always be a proportion of the population who still will want face-to-face and will want to deliver services in a different kind of way. And what we're saying is it is not one size fits all, and it's about making sure that that we have a blended approach to it. But I thank you for raising the point. It's a well made point.
Thank you. Thanks so much.
I believe Jane Hatter's got her hand up and would like to ask a question. Jane?
Yes, thank you very much, Val, and thank you very much for the presentation tonight. And I just want to sort of tease out a bit more about this clinical strategy and what you're doing in terms of trying to reach out to people in this very difficult time. Having consultations during the pandemic is extremely difficult. You know, certainly we found that in the Welsh Government, because obviously there are a lot of people who can't access Zoom, who are digitally excluded. So I'd like to know what you said, that you are reaching out to a number of stakeholders. Could we have a list of who you're reaching out to and how they're going to get approached, because they can't meet, you know, they can't come into a hall or a community centre and meet to discuss these issues. And some of these are the very people who this, you know, your presentation about the future, the shape of clinical services, that absolutely is going to affect them. And I very much welcome the fact that you see this about designing services with patients, for and with patients and their carers. And I just don't think now's the time in the pandemic still, and moving out of restrictions and gradually as we are in Wales, it's going to be very difficult for you to get a real feedback. Certainly you know, in a few weeks' time, I think it's got to be a much longer process to be able to, as people can, hopefully, as we move forward and with the success of the vaccination programme, etc. But the very people who came in large numbers to consultation meetings, I remember in the civic offices when we started this a few years ago, they can't come. I mean, they don't know about this meeting. So I do want to know how you're going to reach out. I'd like to know from South Glamorgan Community Health Council how you feel, you know, we can get patient engagement of this kind. Because also I think it's really important that we look at local services, and you know, this is where, you know, I'm here as Senedd member for the Vale of Glamorgan. Sorry, I should have introduced myself. But obviously very concerned about Barry Hospital, particularly in the services there. And also, can I just say what a fantastic role Barry Hospital has played through the pandemic. You opened up another ward, Sam Davis ward. Thank goodness that ward was still open during this period of time. So I think these are, you know, I just want to sort of put this onto the shared virtual table today as really important issues that we cannot move forward without properly engaging people in what will be, you know, very serious decisions for our Barry community particularly. Obviously, I hope to be joining you on Wednesday night as well. So that's really what I want to say. Can you tell me how you are going to reach out in this very short period of time, very difficult period of time, to make sure that we do get this engagement? And also, at what point would you then, and perhaps this is for the CHC, move to a formal consultation, if it means changes of services of the kind that I'm speaking about? But thank you very much for at least starting the conversation tonight. Thank you.
Thank you. Hello?
Hello.
Steve, do you want to answer that bit first?
Yeah, I can answer the CHC bit, and then perhaps ask Vicky or somebody then to come in on the health board side. From the CHC point of view, we've obviously signed off the engagement plan for this process, and I'm fairly comfortable with the outreach that the health board have been doing by meeting with various third sector organisations, etc. The plan, just for clarity, there's no proposals in the presentation you had tonight, any firm proposals being mentioned. This is a conversation as to how the public can shape the thinking of the health board going forward. So, what will come out of this is, for example, on the principles, do you agree with the principles that you're being asked to support? And then from that, there will be further work that will come out, which will require more a further period of engagement and possibly public consultation on those particular work streams that fall out of this discussion. So Jane, this is the start of the conversation, it's not the end. As far as the CHC are concerned, we've been very clear with the health board that these are conversations and a blank bit of paper, basically, although the principles that we're asking, but actually any work that falls out of that then will require further work, engagement, or possible public consultation. The other thing is that picking up, this is a difficult time to try to engage with people. Yes, we would fully support that. And I think that's why we're having ongoing conversations with the health board on how we take this forward. And again, we've got a midpoint review meeting on Wednesday to see where we are within the process. And maybe there may be a further section of engagement that we may have to look at doing when we're able to go back out and have a further conversation, not only using sort of digital means. Hopefully that gives you some assurance that we're working very closely with the health board to ensure that we try to encourage as many people as possible to feed in their views.
Thank you, Steve. Would the health board like to reply?
That's a very helpful response, Stephen. Thank you. And Jane, we're happy to share, if you'd find it helpful, the kind of the detail of what's in the engagement plan that the CHC supported us with. So I agree with you. It's really important that we can hear as many voices as possible. So we have put information out through a number of different channels in terms of providing information into our GP practices, information's in our mass vaccination centres, which are clearly getting high footfall. So hopefully people will see that and will be able to connect via our website and see the information and provide feedback. But I think the important thing is, as Stephen said, this is not the only chance. As we further develop plans, we'll be out talking to groups as part of a kind of a continuous engagement process, and we'll happily share that with you, Jane.
Thank you, Abby. I believe there's somebody on the phone who would like to ask a question. Unfortunately, I don't have their name.
No, Chair. No, Chair. They haven't put their hand. They physically can't show their hand. So what I suggest was at the end we could ask them to answer the only comments. We've got Ivan got his hand up. Eleanor, and Linda.
Okay, Ivan, would you like to ask a question, please?
You're muted, Ivan.
Can you hear me now?
Yes.
Yes.
I'm very impressed with the effort and work that's gone into this so far, and it's very, very interesting. And the future looks quite rosy, really, in some respects, with the effort that's gone into it. But I'm just wondering whether it's radical enough. I mean, there is good evidence, you will know better than I, that in cancer, for example, direct access to specialist services, the cancer pathway. I think Finland in particular, New Zealand have produced some really outstanding evidence that to bypass primary care and go directly to the expert services provided at secondary level does improve patient outcomes significantly. And I'm just wondering whether perhaps GP services are the elephant in the room and whether this has really been explored as much as it can. Thank you.
Thank you, Ivan. Would the health board like to reply?
Yeah, if I make a stab, I can't see Nav's face, but I'll probably draw Nav in. Ivan, I guess, you know, if you take cancer, one of the things that we are very aware is that the late presentation of conditions, and one of the things that we are working on and working with other health boards on is how we can ensure patients can get into definitive diagnosis when they've got vague symptoms, because often somebody has a bit of a tummy ache or something that's quite a vague symptom, and actually it's about making sure that the GP can access a process that enables vague symptoms to be properly investigated, so that people can get a definitive diagnosis and then on to a definitive treatment pathway if it is discovered that they do have cancer. So that is part of the work that we're doing on the cancer pathway with GPs and with secondary care. I guess it's a balance, isn't it? Because primary care, most of the time when we go concerned about something, it won't be something nasty, but clearly we do need to make sure that people can get in quicker when it is something that needs to be treated quickly. So would support you in terms of how we get patients in quickly. Now, do you want to say something in addition to that?
Yeah, I'm happy to. I'm really sorry that the audio was coming in and out when I was listening to.
So Nav, I think that's, have you got it on English on the interpretation? If you turn that off, because
Okay.
otherwise you're hearing the interpreter's microphone that rather than, I suspect that was probably was. So the question was about pathways in other places in Europe, particularly Finland, where there's a kind of real fast track into the specialists, sort of not bypassing, but not getting delayed at the primary care level, but straight into a specialist.
Absolutely. I mean, the other thing, just to note that lots of people are not on mute, and so I'm getting quite a lot of reverb. So sorry about that. If other people can, everyone mute their microphones if you're not in the conversation. Thank you. So no, I think that's an extremely important point, and we are aiming. I mean, we're lucky in the sense that we're looking at an entire system-wide approach, and we are in a position as a health board, having done extremely well in the last few years in terms of our performance in NHS Wales. We're in a position of being able to look worldwide at best practice. And that certainly doesn't mean the most expensive practice, but it does mean world-class, if you like. And we've got a need to do that for lots of reasons. So we are looking around the world, actually, both in terms of exemplars, but also in terms of infrastructure support for that. So no, I think it's a point very well made. I would just add in that even though this presentation has been about the broad brushstrokes, there are an awful lot of pieces of work that are ongoing anyway. And so the single cancer pathway, transforming diagnostics, those things are going on anyway, but we're trying to make sure it's integrated and aligned with the wider piece, as opposed to one area shooting ahead, perhaps at the expense of another area. So pulling it all together in an overall piece, I think will offer real strength. And it does mean, for instance, that where things work in a cancer diagnostic pathway, we could adapt that to other important pathways, and equally things that are working well, integrating health and social care for any group of patients, long-term conditions, that will be equally applicable to cancer patients. So it does give us an opportunity to cross-check, but I think our aim is high. Our aim has got to be world-class. You know, as I said, I'm pretty grateful actually for the opportunity to be able to do that.
Thank you.
Chair, we've got 3 people with their hand up. We've got Linda Donovan, Eleanor London, and Anne Evans.
Okay. Linda, will you like to ask a question, please?
Thank you. First of all, I'd like to say that I think that all of the documentation that you've produced is really easy to understand and clearly states out your case as to why the changes need to be made to the services to take everything forwards from here on in. Notwithstanding that, I think there's been a tremendous amount to be learned from COVID, and particularly the long-lasting effects of the chronic COVID. And I guess it's about ensuring that all of that is going to be built into your plans, and to the greater need for community rehabilitation, longer-term recovery, and so ensuring that that balance is made. And then I guess the biggest bit really is around the country is hemorrhaging money at the minute in relation to responding to the pandemic. How are you going to ensure that the right level of money comes into the health board to allow you to actually take your programme forwards, to ensure that things are done together and not in piecemeal?
Thank you, Helen. Abby, would you like to answer that?
Yeah, thank you, Linda. You're right, we have learned a huge amount, and we've learnt, of course, about how we treat patients with COVID. And one of the things that has been particularly positive experience is that as a teaching hospital, university health board, working very closely with the university, being able to participate and being right on the front foot in live research that's taking place a significant number of our COVID patients were able to participate in research trials. And there is no doubt that that will have helped us learn about COVID, but also improve the care and treatment that we were able to provide with those individuals. So we are still learning about post-COVID and long COVID, and what that means in terms of the services we need to provide. And we are reflecting that, Linda, in two ways. We have pulled out rehabilitation and what we're calling prehabilitation, how we can get people fit for surgery before they have surgery, as part of one of the strands of the clinical services plan moving forward. So very explicitly developing our thinking around rehabilitation as being such a critical element of our pathway. And clearly long COVID will be very much part of that. And I guess that's where working very closely with local authority partners, so that for people who don't need very specialist rehabilitation, but actually do need programs that can be delivered in places like local leisure centres, we really want to do that, because actually getting people treated in their local facilities close to home is really positive. And then it's about where people may need more specialist rehabilitative support, that we're able to provide that too. We have done, Fiona Jenkins, our Director of Therapies and Lifestyles, has done quite a lot of information and has led the work across Wales. And we've got a lot of material now on our website about COVID recovery and rehabilitation, and we'll be building on that. And I think Nav and Vicky have alluded to, there are all sorts of other things that we've learnt through COVID, and we've had to prioritise, and we've changed the way we've delivered services very rapidly. And so I think it was, Vicky, one of your slides, you talked about CAV 24/7 as a model. We had to introduce that very quickly because we couldn't cope with the same number of people who would normally turn up at our A&E departments and keep them safe in terms of distance apart from one another in line with the COVID requirements. So the new model of phone first and directing people to the right level of care, and book them into an appointment in the A&E department if that's what they need for the non-emergency cases, has been really good to develop and a good example of that, and we're tweaking it and further defining it and evolving it as we go forward. So I think on a range of different areas that there is so much to learn, and we are making sure that that's part of our annual plan going forward, and our sort of recovery plan, of which this is part of the jigsaw puzzle, really. So thank you for that, Linda. Really helpful question.
Thank you, Abby. I believe Eleanor London now has a question to ask.
Yes, thank you. My name's Eleanor London. I'm a member of the Community Health Council. Vaughan Gething today in the press conference did make reference to major health inequalities, particularly in poorer areas. Now, part of your proposed strategy is for more home care and self-management of long-term conditions where possible. Now, we've already spoken about the shortfalls in digital inclusion. My concern with that particular part of your strategy is that for people with perhaps a lack of education, crowded homes, lack of privacy in the home, the model of home care and self-management may actually lead to greater health inequality. So my question really is around how are you going to do an impact assessment of those areas that, to ensure that people don't just get left behind? And I'm thinking particularly of the public health messages have tended on occasions not to get through to people because they perhaps don't engage, don't understand. And I fear that it could lead in some particular areas to greater health inequalities. And if I could just add a quick question at the end, a couple of people have referred to the CAV 24, and I would like to ask, is it still being piloted or has it been made permanent? Because when the pilot started, the numbers coming through A&E were greatly reduced. There were no students in Cardiff at one particular point, and I'm concerned that it might have crept in as a permanent development without being fully piloted in normal circumstances. So I've made 2 points in one, sorry.
Thank you, Eleanor. Abby, can you?
And again, Nav may want to comment on this. Thank you, Eleanor. The issue about the health inequalities is in its sense at the heart of our plan and our strategy. I guess there's real concern that coming out of COVID, that we'll see a worsening of the health inequalities of our population for economic reasons, if people have been furloughed, or in if job opportunities aren't there for people. So two things I would say in response to that. One, we will be working very closely with the public service boards, because health is not just a matter for the health service. It is about the education we're providing, starting early with those messages about healthy lifestyles and positive lifestyles. So right the way through the kind of life course, ensuring that we're enabling people to make healthy choices and support people to do that. And just a couple of examples that it might be useful to draw upon. Across the Cardiff and Vale patch, we've got some really good pockets are working very closely with our perhaps some of our more deprived communities. And I'll draw you to one example. It's not in the Vale, but it's close by in southwest Cardiff, the southwest cluster in Ely, where a combination of the work that the GP cluster there has been doing with the third sector using social prescribing has actually resulted in that cluster having a lower admission rate and a lower readmission rate than some of our other areas, because they're working really closely with the local community and really embracing social prescribing. So engaging people I guess not the usual types of things that are important. So getting people out in their community, helping with gardening projects that help both physical and mental health and well-being. And I know that the clusters in the Vale are doing similar things. So the southwest cluster was our sort of pathfinder, but some of that learning is now being rolled out. So I think we have got some evidence about how we can tackle those things, but you're right to raise it as a concern. And of course, some people may need more support than others, and our prevention, early intervention work needs to be targeted to where it's most needed and where it can have most impact. So, important issue to raise. Thank you.
Thank you, Abby.
Can I just ask about the CAV 24 as well, please?
Oh, yes, sorry, apologies. So CAV 24/7, it's still being evaluated. We're still not back into normal times. We're building on it and looking at the data and the evidence and the feedback as we progress. No permanent decision has been made. We understand that other health boards across Wales are being asked or have been asked to implement similar models. So our sense is that it is moving in the direction of travel that we think is the right way, but we've got to keep listening to the feedback and make sure that we adjust the service model to reflect that. So I think the Community Health Council is still involved in those conversations, Steve. I believe in sitting on the project board, aren't you, for it? So
yes, our chair does that.
Yeah, you're probably more up to speed than I am in terms of the latest kind of feedback and presentations on that. So that's where we are with that, Eleanor. Thank you.
Thank you.
Very briefly about the inequalities point raised. I think it's a really important point, and it's something which our quality impact assessment has already picked up in terms of the accessibility of some of these services. And Nav and I presented earlier this morning to third sector partners, and particularly there was a fairly good, robust discussion around the BAME community, how we can make sure that accessibility for communities is built in from the start. So we will regularly be working with a lot of, as Abby says, the third sector and also partners, so that we can ensure that accessibility as a common theme throughout the programme is continuously highlighted. But we will keep updating that assessment as we progress.
Thank you, Vicky. Anne Evans now, you have a question, please?
Hi, yes, thank you very much. I'm a former member of staff. Hello, Helen, one of Helen's staff, actually. And a local resident, until fairly recently, was a carer for my very elderly mum. I really, really struggled to get the care my mother needed. How anybody elderly on their own, without a, could I be sexist and say daughter, but without a local relative, and in particular one who knew their way around the system, how people cope, I do not know. She couldn't use a mobile phone. She couldn't even get a GP appointment because couldn't manage to ring, at 8:30 on the dot. It was a real struggle. And it was hard enough for me as a retired member of staff who lives very locally to help my late mother actually get the care she needed. I really think we've got to go back to absolute basics, how people even get GP appointments when you can't keep pressing the button on your mobile phone. The second point I'd like to make, so I'd like to come back to that, but the second point I'd like to make is I really think that we need to look a bit more closely about the various hubs. I run the local civic society in Penarth, and as I understand it, the plan is to build the hub at Cogan. It's actually difficult to think of a worse place to access in Penarth. Very, very difficult for local people to get there. Barry Hospital, I appreciate Barry is there and ought to be a resource that's used, but we really need some joined up thinking in terms of transport. I mean, Penarth is one giant queue of traffic in the morning. Actually getting to the hub will be a nightmare. And Barry Hospital, last time I checked, there was one bus a week from Penarth to Barry Hospital. We need to be looking at some absolute basics here. Can I go back to the first point first, please, though, about the elderly?
Yes, please. Would the Health Authority like to address that issue?
Yeah,
Sorry?
thank you. And sorry to hear that the experience you had with your mother, Anne. I guess many of us are now carers for relatives, and I agree with you. It's not always easy to get the right care and get that organised. I think one of the things that a Healthier Wales flagged, and we are trying to do through our regional partnership board, which is a partnership between the two local authorities and the health board and the third sector and the housing partners, is to make that much easier for people. So I don't think we've got it right now. We've still got much more work to do, but we are looking at how we get a single point of access so that we can get early indication of when people may need care and support. So whether that's that they're already living in the community and the GP picks up that there might be a care and support issue, or an individual themselves, or as you've described, a member of the family picks up that there may be care and support requirements, that we've got kind of a single gateway to enable people to get an assessment and find out what is going to be the right support for them. The government at the moment is consulting on a white paper on balancing care and support, I think it's called, or rebalancing care and support. And again, that picks up on some of the challenges about the social care element of that, and how we can improve on ensuring people get the right kind of support, and ensure that the services that are provided there are available when people need them and they can access them easily. So I don't have all of the answers to that at the moment, but it's certainly something we are very aware of. And when we've done engagement work, and I know the government did some engagement work to inform the white paper, there were some clear messages about how difficult it can be for people to get the right kind of support for their loved one, and to navigate their way through the system. So I think we have made some improvements, but I think there is still more work to be done. And you raise a really important point. The second,
could I say something there as well?
Yeah, Nav, please do. Sorry, I was going to come back to you, but I'll come on to the second point after you. Thank you, Nav.
It is difficult, and well, it's an extraordinarily difficult issue to grapple with across the board, really. In terms of the way we're approaching it for shaping our future clinical services, which is this programme of work, although it clearly interweaves with health and social care and population health. In terms of clinical services, we have a few absolutely crucial cross-cutting themes that cross all clinical pathways, really. And the frail older person is one of those major themes. So we'll be putting some program resource specifically towards looking at frail older people. I think that's going to be a bigger population and a bigger challenge than perhaps some of the other, for instance, non-English and non-Welsh speaking minority ethnic groups, more vulnerable groups as well. There are 3 or 4 cross-cutting themes that we are going to be specifically considering across the board. Another one is mental health, because it affects all of the, you can divide it into planned elective care, emergency care, and regional services, but mental health care cuts across all of those as well. So the frail older person, we are going to try and consider across pathways as well as within pathways. Again, it's an answer that's specific to clinical services, but if you're talking about trying to contact your GP, then you are talking about a clinical service, not a social service as such. So yeah, it's something that we are actively thinking about right now. I clearly can't give you all of the solutions just yet. It's very much part of our plans.
Oh, thank you very much. That's really interesting. I was really shocked at how difficult I found my way to navigate around the system, which really makes me wonder how other people, without my years of experience in the health service, how do they manage?
Abby, did you want to come back in on the second part of the question?
Thank you. Just fully accept the comment made by access, and I think Nav's point around access and transport. We have got more work to do with local authorities to ensure people can get to the key places in terms of where services may be delivered easily via public transport. That's clearly an essential requirement in terms of planning, because we need to kind of reduce our dependence on independent cars as part of our carbon reduction requirements. So I heard what you said around that. It was difficult finding a site in relation to the conversation in Penarth, and we have listened to the views of people as part of that engagement process, so understand some of the issues and challenges, but working very closely with our authorities to make sure these things do join up as they need to enable people to have access. So yeah, again, I think that's a really important point to have raised this evening for us to hear. Thank you.
Thank you very much.
There's somebody called Helen who'd like to ask something. Helen, are you there?
Yeah, she's muted.
Helen, you're on mute still.
Is that okay? Can you hear me?
Yes.
Yeah, sorry, I've got 2 unmutes here. I'm Helen Nichols. I'm the Community Dietetic Service Manager for Cardiff and Vale. So thanks for letting me join this evening. It was a couple of points that do relate to some of the earlier discussion. The first was that our dietetic service, but also other therapy services, do deliver a lot of the self-management programs and healthy lifestyle programs at the moment. And we also support the third sector with training. And we're trying to use a blended approach. So hopefully going forward, we can use more face-to-face, but we do online as well. And we are finding a lot of people, even if they are digitally enabled, would prefer face-to-face group education and that peer support. The comment really relates to the slide that Nav showed with the home-to-home pathway, that it's still showing the first point of contact as the GP. And I think we need to think wider and slightly broader in that medical model. And there's a lot of first point of contact services currently with physio and also mental health, but other therapy services such as ourselves have the opportunity to help divert people away from the GP specifically. So that was the first point. And the second was relating to estates. So we've mentioned about UHW, but the community estate, we need to look at that. I think even with the wellbeing centres, we're still going to have issues with our community estate, and we need to look at where all these community staff are going to be based. We're currently struggling with estate, And whilst we're delivering virtual services, we still need somewhere fit for purpose to deliver those from, to ensure that it's a confidential virtual consultation from the patient's point of view. Thank you.
Thanks, Helen. So almost identical points that were made by the community pharmacists that we had a meeting with, and I'm not sure exactly when we're meeting with community dietetics, but I'll be surprised if it's not on the list. Vicky and I have been we've been addicted to Teams and Zooms in the last couple of weeks. To be fair, the error on the slide is mine, and by GP it should have read, first contact could be primary care in totality. So it's a point well made. It's an error on the slide. We didn't want to change the slides halfway through, to be fair. So yeah, point well made and already on board. Thanks for that one.
Great.
In terms of the infrastructure, yeah, I'm afraid that I think that people might get swayed by the headline, because it will be such a big headline around hospitals, but we're well aware of all of the infrastructure requirements, as well as, for instance, for community pharmacists, they're independent contractors. It's not NHS infrastructure as such. How do you square that circle? It's complex, that one. So, we've got that in our sights. I think that the infrastructure has to be fit for purpose, wherever and whoever. Points well made.
Thanks.
I think, by the way, Chair, Max Wallace has had his hand up a couple of times, just to note that.
Thank you. Mark, would you like to answer some question? Mark?
Yeah, I was going to say just a couple of things. I mean, I think one important step here is engaging with councillors on many levels. As you know, I'm a Vale councillor, but just as important, and in some ways, more important in some ways, town and community councils, because there's many more of them in terms of councils, especially in the Vale Glamorgan. And it's seemingly, like, for instance, there's 16 of us on the town council, and it would be quite good to get a presentation of this to the town council at some stage within the next year. And it'd be quite good, therefore, to then have a consultation with the residents of the community of Penarth from this. I think that'd be very, very useful and helpful as well. And obviously some sort of plan about the next consultation phase, when you narrow down the options a bit more. I think that would be also useful as well. Thank you.
Thank you, Mark. I believe Max Wallace, Mark Wilson has got a question.
I've already asked it.
Sorry. Linda, did you want to come back on a question?
Sorry, Chair. It's Max Wallace was next, and then Linda.
Max Wallace, then, please.
Yes, thank you, Chair.
Sorry about that.
They said it was 3 years there's been gestation of this plan, particularly the wellbeing centres. And so COVID has happened since then. I looked for changes in the plan relating to some COVID assessment, and there's hardly any changes because of that. So I'm thinking of the Cogan Hub, Wellbeing Hub, where you have integration with social services is a intention, integration with the leisure services, or that's Cogan Hub, a common entrance, sharing loos and the cafe, all this combining with people who are healthy of the ones who are going for health reasons. You're sharing rooms, which, people, the shared rooms in the place. Now, I imagine that the health board will have a high level of cleaning in the rooms that it controls. The high level of cleaning, specialist cleaning, even won't be available there. It won't be under your control in the leisure centre combination. So we're rather concerned. It was raised even before COVID about infection being transferred in such an environment. And surely after COVID, you're going to want to review this model of integration with so much else so much other sources of infection, which you won't be able to control. Thank you.
Thank you, Mark.
So I'll come back on 2 points, and Nav, you might want to give a clinical view. Thank you for that, Max. Just to let you know that not because of this reason, but the plans for Cogan are evolving, and we are taking another look at the plans for Cogan. So there isn't a completely fixed plan at the moment, and we're developing an idea of a campus that might have more of a separation between the leisure centre itself and the facilities. So that's still work in progress, and we're happy to share that as that evolves. But I guess, Nav, there will be many places where we are trying to develop a model where there is integration between services, because, and notwithstanding at all, Max, the important point you raise about infection prevention control measures that need to be in place. But the idea is that many people will come into a primary care, and actually many of the issues that they may be facing don't have a single organisational solution to them. So they may be having anxiety and depression, which might be relating to their housing tenure and housing issues. So trying to get models where we're bringing services together, building on some of the experience in places that are regarded as really the leading light. So Bromley by Bow is one of the examples that's held up as one of the best examples of health and wellbeing centres. So it's about finding a way of balancing those two, the opportunities of bringing services together and making sure that the risks are managed. Nav, do you want to get anything more from a clinical perspective about managing those? I guess we do that in hospital all the time, because many people who come in won't have an infection, and other places will, and we manage that well, don't we?
Yeah, I think that infection and COVID obviously is a live subject. I think that the challenge to us to change major plans whilst we're still coping with a fairly unprecedented pandemic has been a big one. So I hope that people will understand that we've been dealing with the illness itself, as well as changing the way we work and changing the way we plan at the same time, and we're learning all the time. But these facilities that we're talking about effectively are for members of the public who have got healthcare needs within that sort of public environment, as opposed to within a hospital environment. So I sincerely hope that we will be back to rubbing shoulders in the rugby stadium, drinking in pubs, eating in restaurants, working out together in sports centres, and members of the public with or without healthcare conditions will be doing those things. So I think it's a question of where the right environment for those different elements is for a person's healthy, active lifestyle. And it is work in progress, and there are great exemplars around the world that we're looking at. I think in terms of more medical type clinical facilities, there has to be clear separation for clinical reasons. So I think there are multiple different objectives to health and wellbeing centres and wellbeing hubs. But I think we've spoken a number of times about things like how it interacts with poverty, how it interacts with hunger, education, and hard to reach vulnerable groups. So by extending clinical services into communities, I do think there is an opportunity for us to reach the people who need it most. I think the point was well made that it's the most difficult to reach people who traditionally access it with most with the least availability. So it's trying to get into that I think the community care element is our big opportunity. Less focus on clinical care, more on that holistic approach.
Okay. Linda, have you got another question?
Thank you. Abby, thank you for your reply. with regards to rehabilitation and the incorporation of that. I suppose what wasn't answered was around the balance of being able to achieve the financial resources to actually move things forwards, and Helen's prompt in relation to our community estate just made me want to come back on that, really.
Linda, apologies, you're absolutely right. I wrote it down and then didn't come back to it. So I guess you know, you're right that the COVID will have impacted on the finances of government, both in Welsh Government and in Westminster Government. And I guess for me, that's why it's important that we are able to transform the way that we deliver care, because we are going to need to do things differently. It's going to take us a number of years to recover from COVID. We've lost a lot of activity that would have routinely come through the system, and we're going to have to find different ways of responding and meeting those needs of people as we go forward. So we would hope that by having a very clearly articulated plan with different stages to it, including the shaping our future clinical services, which kind of provides the umbrella for a number of developments that will take place underneath it, we're able to develop a suite of business cases, some which will be about capital money to develop our facilities. So we have a range of capital programs being considered at the moment, so that we have the right kind of facilities that we need moving forward. So if I give you an example, we know we will need more surgery undertaken, and we've got a backlog of surgery. So again, we're looking at how quickly we could develop in line with direction of travel, more theatres at Llandoch to enable us to undertake more surgery over there. So it will be incumbent on us as an organisation to make sure we've got a compelling case through this engagement and into the consultation, if there is a requirement for consultation, so that that when we go to seek capital investment, if it's a capital development that we require, that we have a good strong case to secure the right kind of funding, because just like us, government will need to make some difficult choices around that too. And then in terms of the revenue, the funding we've got available to us, we know that government has been able to support us in terms of our COVID response and provide additional funding for the things that we've needed to put in place. But we know that's as we come through the pandemic, kind of our normal planning and financial regimes will come back into play. And again, for me, it's part of the same jigsaw puzzle, really. We will have a large amount of money that's invested in our services to make choices about with local people about what's important. And I think what A Healthier Wales talked about, I always describe it as the pizza diagram, but it talks about, you know, we need to move from a place where more things are happening in hospital than really need to happen in hospital, and we need to flip that and do more of those things in the community. And we need to make sure that our financial model follows that, so that we're able to disinvest in some bits of the hospital pathway, as Nav described, because we're able to do more in the community. And for me, it's about how we do that as part of our planning process. So it's thought through, and that we use things like the Intermediate Care Fund and transformation monies to enable us to pump prime some of those services that we need to have in the community, and build on the things that we've started developing in the community, and build on those. So again, it's often challenging, but that's the challenge that we have to take forward as part of this plan. So thank you for that.
Thank you. Are there any further questions, please? No, well, if there are no further questions, we have now come to the end of this engagement meeting. I wish to thank the speakers for their input, and also the clinicians who have taken part. I especially thank you all for attending and feeding in your comments, questions and observations into this meeting. We will ensure that the views, comments and observations you have expressed will be taken into consideration in the discussions that the CHC will have following the end of the engagement exercise, in order for the CHC to formally respond to the Health Board. Could I also remind you that your opportunity of having your voice heard is to complete the questionnaire and return as indicated on the form. Finally, thank you all once again for attending the meeting. And can I ask the Chair of the Health Board if you would like to say a few final words?
You're finished.
Thank you, Chair, very much. And I would like to say a really big thank you to everyone who took valuable time out this evening to attend this engagement session, and for the very important contributions you've all made. If you could spread the word, please, amongst your colleagues in the communities and those who represent communities, please also ask them to be involved. We'd really appreciate as many views as we could possibly get. And as Stephen said earlier on in the session, this is the start of the conversation, so there's some way to go yet. But we do appreciate very much your kind input this evening. Thank you all very much.
Thank you very much for those nice comments, and good night to everyone. And this meeting will now be finished.
Thank you very much. Thank you.